Thank you. Thanks, everybody. I'm sorry that you don't get a little picture of me. You'll just have to imagine me, but I'll show you one somewhere down the road. But I'm going to talk today about the care of children dependent on respiratory technology, both invasive and non-invasive ventilation. I have done some work for Philips, although I think that will have little or no bearing on this talk. So, supporting somebody with artificial ventilation outside of an ICU is not a new concept. It goes back even to the Princess Bride, but it is a little bit unique over the last 40 or 50 years that we can support children so that they can go home and play in their backyard while still being supported by ventilation, or go trick-or-treating, or have a nice picnic with Mom, or even just have a great morning snack of chocolate pudding. So this is a picture when I was a senior fellow. So for those of you I've not met, that's me. I look exactly the same now, well, maybe 20 or 30 pounds difference and a whole lot less hair. But the star of this picture is this little guy. And he really is the person who got me jazzed about taking care of children with chronic respiratory failure. So he was a boy with pentalgy of Cantrell, and he had ectopia cordis and pulmonary hypoplasia and chronic respiratory failure. And he never left the hospital until the age of about 4.5. And this was his first day outside of a hospital bed. So here he was just about 3. And you can see how much we respected him. So there's my attending. For people who might know him, that's Jules Allen. There's 3 residents, a respiratory therapist, and 2 nurses, all for this little guy. So we certainly had a lot of respect for making sure he'd be safe just walking outside of the hospital at St. Chris's. And I will tell you, he was terrified to feel the breeze on his face, and somebody honked a horn, and that sort of put him over the edge. And it was my first realization that's just not the way for somebody to grow up. This is the Christmas card from that year from the unit that John lived in. It's called the Special Care Unit at St. Chris. And around the holidays, one of the big department stores in the city gave all the kids who were still in the hospital these bears for a Christmas gift, and each of the bears had a little red vest on. So the nurses of the Special Care Unit thought it would be cute to dress the kids in the unit with the vests and the hats that came from the bears. And this was the Christmas picture for that year from the Special Care Unit. And while it's cute, I think, once again, it highlights this is just not how we want kids to grow up. And so when we think about why we want to perform the task of sending somebody home with mechanical ventilation, these are the goals that have been espoused both in adults and children, and I've adapted them for children. So first and foremost, we want to extend life and enhance its quality. And in some cases, that's not possible, so at least we want to palliate dyspnea. Certainly, we want to reduce morbidity. That might mean not doing tests on somebody. Every time somebody has a fever doesn't mean he or she requires a sepsis evaluation, and certainly we don't do that when kids are at home. We want to improve physiologic function as best as possible, and we want children to achieve normal growth and development whenever that's possible. And then ultimately, the important thing is we want to do this in a cost-efficient way and keep that in mind as we provide services for children and their families. So there are lots of different types of patients who might benefit from home mechanical ventilation. There are lots of different ways to slice this pie. This is one way that I think is a simple way of doing it. So you can think about problems with the respiratory pump, and the respiratory pump includes the muscles of respiration along with the rib cage and the ventral abdominal wall. That's all considered part of the chest wall. There may be problems with respiratory drive. Children can have either extrathoracic and or central intrathoracic airway lesions that require mechanical ventilation, like tracheomalacia or tracheal stenosis. And then, of course, there's the big category of pulmonary parenchymal and vascular problems. So just as a snapshot, this is the home ventilation program. The left-hand side really are the kids that were at St. Chris, and then I came to Children's Hospital of Philadelphia in 1998. Some of those patients came across the river with me, but there were several patients in the pulmonary home vent program here. But you can see that over the years, there's really been an exponential increase in growth. And so now we have about 850 children in the community whom we follow with either invasive or non-invasive ventilation. And if you want to break that down a little bit more into categories, I've broken them into a bunch, but they still fit within that more simplistic way. So we have kids with some airway disease, whether that's central, intrathoracic, or extrathoracic. Children with heart disease. This is largely children with bronchopulmonary dysplasia, but there are some other chronic lung diseases included in this group. Children with central nervous injuries, and children with problems with control of breathing, like congenital central hypoventilation syndrome. Other children who have neurologic disease like cerebral palsy or neurometabolic problems. And then we have a large population of children with neuromuscular disease. Separate from our sleep program, we have a few children whom we follow with obstructive apnea. And we also have a thoracic insufficiency program, so we have children with restrictive lung disease. And you can see that the yellow parts of these bars are children who receive non-invasive ventilatory support, and those in red receive invasive ventilatory support via tracheostomy. So it doesn't matter what the category is. When we think about sending somebody home with mechanical ventilatory support, they have to fulfill certain criteria, and here I've laid them out in broad brushstrokes. So at the time that the child goes home, that child has to be medically stable, and I'll talk a little bit more about that. We have to have a good environment and supports to send that child home to. There has to be adequate reimbursement for the care that has been otherwise reimbursed in the hospital. And it's important to have a community organization to help keep the child safely at home. So let's talk about some of these categories. So let me start with medical stability. So we can think about medical stability from a clinical standpoint, and for children who are supposed to be growing, we want them to have a positive trend on the growth curve. Clearly, if you have a young man with Duchenne muscular dystrophy, you don't want that guy growing too much so that he becomes obese. We want the patient to have adequate stamina, either to perform therapies or for periods of play, and the child has to be free of frequent fevers or infections. If we want to talk about physiologic measurements, the child has to have a stable airway. That could be the natural airway if we're doing non-invasive support, or a tracheostomy if we're talking about invasive ventilation. If the child has lung disease, then we want the PO2 to be greater than 60 millimeters of mercury with an FiO2 less than 0.4, and that really is a practical measurement. It's hard to supply higher concentrations of oxygen at home, and there's very little room for deterioration once a child requires that much supplemental oxygen before that child needs to be urgently re-hospitalized. If the child has lung disease, then we want the PCO2 usually to be less than 50 TOR. But if the child doesn't have lung disease, for instance, if the child has neuromuscular disease, we would expect a normal PO2 in air, and we would expect the PCO2 to be normal as well. And then we don't want the child to require frequent ventilator changes in order to maintain the stability. So there are a couple of things I want to point out here. First and foremost, the only thing that I've specified in terms of a ventilator setting is the FiO2. So at least in our practice, there is no pressure that would dissuade us from sending a child home as long as the child fulfills all other categories of stability, which means if a child requires a PEEP of 15 or 18 centimeters of water, so be it, as long as that keeps the child stable. If the child requires a peak inspiratory pressure of 50 and we have a ventilator that does that with reserve, that's fine. And then the other point is listed at the last bullet here, and that is we individualize this. So we certainly have sent kids home not fulfilling all these criteria when it's been a situation where we're really focusing on palliation. And so we always consider each of these on an individual basis. All right, so we have to have an adequate place for the child to go. There have to be caregivers. That could be family members, it could be neighbors, it could be whomever is identified. And for a child with a tracheostomy, we want that to be 2 people. And whichever way things go, these folks have to commit to wanting to help care for the child. They'll be included in planning along the way, and I'll get to that in a moment. And they have to commit to training and also to providing the type of surveillance that we discuss in the hospital just to make sure things are safe. When the child goes home, there has to be enough space for the child, along with personnel and equipment that will be required. There will be lots of people coming into and out of wherever the child lives. And if the child is confined to a wheelchair, there has to be adequate access. We really don't want kids to be confined to bed. We want them to get out and about. So if that means a ramp has to be built or doorways have to be widened, that all has to be taken into consideration before we send a child home. There has to be adequate heat, electricity, and water. We've sent kids home to trailers, we sent them home to apartments, we sent them home to houses. None of that matters as long as the basics are in place. And there has to be a working telephone. We would prefer that to be a landline, but sometimes nowadays people don't even know what a landline is. If there's a cell phone as the only means of communication, that cell phone has to stay with the child. So it does no one any good to have a mother's cell phone number and the mother goes to work and takes the cell phone with her. Because if there's an emergency, there's no way to talk to a nurse at home or the person caring for that child at home. So we just have to make sure we have a way with open communication wherever that child is. And then, depending on how far away the child lives from the tertiary care center, we have to identify community resources. So if a child lives far from us, we identify a local emergency room where in a bad situation, the child could be stabilized and then transported to us. And we identify an ambulance service for the family, etc. Now, having said all that, doesn't mean that we make the house into a mini ICU or a little hospital. So here's the bedroom of one of our ventilator patients from several years ago. Most of you guys won't recognize this type of ventilator, but this was a Seacrest ventilator that was often used in neonatal units. And the Seacrest was a pressure-limited ventilator that ran off a compressor. So there's the compressor that's doubling as a weight table, supplemental oxygen. You can see over in the corner here is a little shelving unit that has all of the monitoring and equipment that might be needed. So there's gauze and bandages, etc. There's the compressor for the nebulizer. And most importantly, this looks like a bedroom. And this little guy's on the floor with mom and dad and joined by his brother. So we try very much not to make this into a little hospital. This is the home of 3 babies with BPD, all of whom required mechanical ventilation via tracheostomy. So the parents, instead of using a bedroom, took their front porch and converted that into the children's nursery. And so all 3 kids shared that, and you can see these little plastic units that held all the medical supplies. Here are 2 of the 3 ventilators, along with monitoring for the kids. There's one of the kids, there's another one over here, and the 3rd one's off to the side. But I think when you look, you can say, well, this doesn't look like necessarily an ICU, and the parents made this as homey as they possibly could for 3 kids, all of whom needed medical technology. So I mentioned reimbursement. There's lots that needs to get paid for. We have to pay for the ventilator, perhaps a backup ventilator if the child requires ventilation for more than 20 hours of the day. There are disposable supplies like suction catheters, gauze, etc. And then the most important expense has to do with nursing salaries. We have to make sure that we have all this worked out before the child goes home so that there is no loose ends here and the family doesn't have to worry, how are we going to afford to take care of our child? There are enough other things that were covered under a hospitalization like pharmacy and nutrition that the family has to pay for, or the increase in utilities that come along with running some of this equipment. So we need to make sure that this is economically feasible for a family. And to do that, we use insurance, third-party payers. There's Medicaid that's a backup insurance for virtually every one of these patients. And for some of our patients, especially the older ones, there are waiver programs that will supplement insurance and allow us to make this economically feasible. So what's the process? Well, we start by assessing both the patient and the family. And if we think that this is a good fit for home, then we discuss the options of long-term care with the family. Preferably we do this for a child who's going to undergo or require invasive mechanical ventilation. We do this before the tracheostomy is placed so that that can be part of a discussion as well, what that tracheostomy care will be, because really that's the focus of much of what we do even when a ventilator is attached to the other end of the tracheostomy. And at least in our region, we are blessed with having several intermediate or transitional care facilities that are options for families, and we make sure that this is as much guilt-free decision that a family would make as possible, because we know that having a child home with mechanical ventilator support really is not for everyone, and we want the family to be able to make the choice that's best for them. Sometimes if it's a single parent who says, you know, I have to work, there's no way I can care for my child at home, we find an alternate method of support until the child's well enough that the child can be weaned from that support and then go home with the family. And we make sure that the family knows that that's an okay decision to make. If, however, they commit, we sort of make this a contract and say there are expectations we have of you in order for us to get your child home safely. And for us, that's about an 8-week program, give or take. Some families who can spend a lot of time and who are facile with procedures might get out of here in 6 weeks, and other families who take longer to learn or can't come as frequently may take a little bit longer than 8 weeks. But we set up what we call our 8-week program, and this is sort of the encapsulated view of that. FLOC is frontline ordering clinicians, so that would be either a resident or a nurse practitioner in our institution. But the thing that I'll point out is look at the asterisks under family. So each of these points along the way, we expect participation on the part of the family while everyone else is doing his or her job. So the home equipment company goes to the house and assesses it for whether there would need to be additional electrical circuits or upgraded electricity for the type of equipment to be used. We get nursing agencies involved. The family has to often meet and interview nurses to make sure that they're compatible. We have, along the way, we've got updated meetings with the family. They have to choose their primary care doc, and we continue to go through equipment lists, et cetera. And then we have a discharge meeting 1 or 2 weeks before discharge. We make sure all this stuff is in place so that by the time the child's ready to go, it should really just be wave goodbye, and our team picks up along the way, and then our outpatient team picks up the day after the child goes home. One of the things that we've been really lucky is to have one of our intensivists create several simulations for us. So I want to show you one here. This is a simulation that parents go through, and this simulation is an inability to replace the tracheostomy. I'll start playing it, and then I'll be quiet. But notice these are the tasks that they're supposed to accomplish throughout the simulation. So the pulse oximeter is here. This is a mannequin for anybody who's concerned.
Okay. Ready?
Empty?
Yeah.
Good.
Yep. 1, 2, 3.
And you can't get it in, Kelly.
Oh, I can't get it in.
I know you're in, but you can't get it in.
Okay. Get the silence.
Can't get it in.
Can't get it in. All right. Pause.
Okay. Let's try repositioning his head first, and now try the shy lead in.
Can you get it in?
Still can't get it in.
Still can't get it in.
Pause.
Pause.
They just did that. Now they're doing that.
911.
Hello. What's your difficulty?
I have a son who's on a trach and vent, and I can't get his trach back in.
We're trying to get him.
We are starting to bag him now.
Okay, we're on our way.
Okay, thank you.
Keep going. We're on our way. We'll be
Okay.
here shortly.
Don't stop. If he stops, he doesn't get any. So I need to pee.
So if you happen to be watching that pulse oximeter drop, I bet your heart rate went up. Mine certainly does every time I watch that simulation, and it is amazing how parents learn how to care for their child and stay that calm and collected when emergencies happen at home. And it's one way that we can make this a safe proposition for them. All right, now, I've mentioned this idea of stability before discharge, and if you read the ATS guidelines, it talks about no changes to ventilator settings. But in fact, stability really has to do with any aspect of the medical plan. So these are data from LA Children's. This is Sheila Kuhn, who's a nurse who runs the program there. And she reviewed their experience over about 7 years, where they discharged 109 patients. And she looked at how many were unexpectedly hospitalized within a year of that discharge. And so 40% of those children were rehospitalized within 12 months, but of those, 19 were hospitalized within the first month. So that was 22 rehospitalizations of 78 total over the year. And she found that the only thing that statistically significantly correlated with the risk of rehospitalization within that month was any change to the medical plan within 1 week of discharge. And so 8 of the 10 kids who had a change in their medical plan were rehospitalized, and that included a change in ventilator settings, or it could have been a change in their chronic medication, so that could have been a change in diuretic dosing, or an addition of a PPI for reflux, antibiotics for inflammation around the gastrostomy tube, or a change in the tracheostomy tube. So really, any change increased the risk for an unexpected rehospitalization. And we have seen similar associations in our population. So our nurse practitioners now very carefully monitor for the 1 to 2 weeks before hospital discharge. They remind folks in what's called our progressive care unit that we don't want to make any changes to the medical plan. And we have seen when the team, and that includes our colleagues in the ICU, when we all remember not to make those changes, we have drastically reduced the number of rehospitalizations from about 25% down to 10%. All right, I'm going to switch gears a little bit and talk about choosing the portable ventilator for your patient, because just like in this picture, one size may not fit all. And so when you think about the type of ventilator that you want to use, I think there are a few things to keep in mind. First of all, know the ventilators that you have available and know what their capabilities are. Make sure that the staff in your hospital understands how to use those ventilators. Make sure that your home care company knows how to use the ventilator that you want to use. It doesn't do any good to have this snappy new machine and nobody in the community knows how to use it. Make sure that the one that you choose serves your patient's needs. Sometimes having lots of bells and whistles is actually detrimental and causes lots of nuisance alarms. And sometimes having a machine that is lightweight and does all cool stuff may not be the one you need because it doesn't have the capabilities you need for your particular patient. So you want to make sure that the ventilator is appropriate for what your patient needs, and I'll go through some of those things with you with some individual machines. So ventilators, since we started sending children home or adults home with positive pressure ventilation, have gone through significant evolution. And so now we're in really third generation machines. And you can see here on this slide the difference between first and second and third generation. So initially, machines like these two, which were first generation machines, were piston driven. Now most of the machines are turbines. There's still one that has micro pistons. These guys were considered portable, but they were beasts. So a 35-pound ventilator, and if you wanted to make it truly portable, you had to add a marine battery. So think about the weight of that plus lugging the toddler around attached to it. Now these machines are quite small and quite nimble, and most have internal batteries. The initial machines only delivered breath in a volume control mode, and there were only two schemes. That was synchronized IMV and assist control. And now we've got machines that have continuous flow and all kinds of modes, so pressure control or volume control with SIMV, pressure support, assist control, and CPAP. As I mentioned, the new machines have continuous flow. The original guys did not, and that was really a deterrent for little babies who were very uncomfortable with that type of support. PEEP was always external in the first generation machines. Now most machines have PEEP integrated within the machine, and when you make changes, it's PEEP compensated. The only trigger that was available was a pressure trigger in the first machines, and now we have flow. Most machines have flow triggers, and a couple also have pressure triggers. There was minimal or no internal battery for these machines, and now we've got both internal and external batteries. And then one other thing that is quite great about the new machines is that we can get graphics and we can also get downloads. So you don't necessarily have to rely on bringing somebody into the sleep lab to see how they're interacting with their machine. You can get a 30 or 60-day download and get lots of good information from that. All right, so there are three machines in our region that we use pretty commonly. We have not started to use the Evo yet, so we're still using the Trilogy. The LTV we still use to a limited degree, and the Astral is another one that we've been using a fair bit. You can see that the LTV was really the first small machine that had continuous flow. Its predecessor was the T-Bird, which was a big machine. But still, now this was considered quite small. In fact, LTV stands for laptop ventilator. So for those of you who think about your laptop now, laptops were a lot bigger back then. So this machine is 14.5 pounds. The Astral is half that weight. The LTV has a battery that's really there for emergencies. It's not meant to be used for an extended period of time, whereas both the Trilogy and the Astral do have internal batteries for extended use. All of these have external batteries. So with routine care, The external sprint pack for the LTV can last 6 hours. There's a hot swappable battery for the Trilogy that lasts 3 hours. And then there's an external battery for the Astral that lasts 8 hours, and you can daisy chain 2 of them together. So ostensibly, you could be 24 hours away from a power source and still have ventilator function with the Astral. There's only one prescription for the LTV, which means that if you want to use a day and a night setting, the family or the nurse or the DME has to change the individual settings between those two, and that can increase your risk for error. There are 2 prescriptions possible on the Trilogy, so you could have a weaning and a standard, or a day and a night, or exercise and rest, whatever you want to choose. And there are 4 programs possible for the Astral. As I mentioned before, you can trend data with both of these machines. You can't with the LTV. The Trilogy uses either an internal SD card, or now there's lots of cloud-based data transfer. The Astral has an internal hard drive that saves up to 1 year's worth of data, but also it uses cloud-based technology to save data as well. Now, here are some other things that might be important for you depending on your patient. So the reason we continue to use LTVs, even though some people feel they're obsolete, is sometimes we need high inflating pressures. We have a couple of babies who have lymphatic abnormalities and massive ascites, and they need inflating pressures well above 50 centimeters. And so neither of these machines really can be used for them, and we have to resort to using the laptop ventilator. On the other hand, we have other children who have severe obstructive disease and intrinsic PEEP, and so sometimes we have to go to 20 centimeters or above, and that might mean that's why we want to use the Trilogy, because we need a higher end expiratory pressure. All of these can have short inspiratory times to pretty long inspiratory times, and this really wouldn't make you choose or not one versus the other. The LTV has continuous flow, but it's fixed at 10 liters per minute, whereas both of these machines are meant to have variable flow so that they can overcome leaks, and they do that much better than the LTV does. So here's my first question for you guys. We're going to talk about some of the settings that we use. So a 9-month-old with neuromuscular disease acquires an RSV illness. She is treated with BiPAP non-invasively in the spontaneous time mode with an inspiratory pressure of 16 centimeters, an expiratory pressure of 6 centimeters, and a backup rate of 10 per minute. She's still hypercapnic despite having a respiratory rate of 45, and the ventilator output shows that her inspiratory pressure does not exceed 14 centimeters. So which intervention would most likely increase her ventilator support? Would you increase the set IPAP to 18 centimeters? Would you decrease the rise time from 2 to 1? Would you increase the rate to 20? Or would you decrease the cycle sensitivity from 30 to 20%? Looks like we have a pretty good spread of opinions here. All right, so it looks like most people would choose decreasing the cycle sensitivity, but that's not going to help you get better ventilation for this patient. And in fact, the answer that I'm going to show you would be to decrease the rise from 2 to 1. And let me explain why. So first, let's talk about, let's talk about what rise is. So rise refers to a characteristic of pressure-controlled breath. So that could be when you're supporting somebody in the pressure control mode or when you're using pressure support. And it refers to the time it takes to go from your baseline pressure up to about 90% of the set pressure that you want to deliver. So the shorter the rise, the faster you'll go from baseline up to your peak pressure. I show you a little bit of data here. This is a bench study that looked at several of the ventilators that I'm talking about. So there are 2 different LTVs here, Trilogy, and a couple of other ones. Bottom line is, so this is with pressure support of 20 centimeters, and you can see that these machines have similar rises with a weak effort. Some of them are a little bit better once you get to a strong effort. Some are a little bit faster than other ones. But in general, the rise is variable on these machines, and it's one of the nice things that you can vary. In your ICU ventilator, that might be the slope. In other ventilators, it might be the profile. And so here, in fact, was a baby with SMA who was being supported, and the set inspiratory pressure was 16, and the rise was set at 2. And I want you to notice that this baby's inspiratory pressure is never getting to 16 centimeters of water. And so you think, geez, this is what we're giving this guy a pretty good inspiratory effort, but in fact, it's pretty much down there at around 14 centimeters at best. The only change we made was to get that rise shortened so we get to hit the pressure faster. And because this baby is so tachypnic, you really need to hit that peak pressure faster. And now look, routinely you're hitting a peak pressure of 16 centimeters. And in fact, the tidal volumes were larger as a result of this, and so we improved this baby's ventilation. So let's talk about cycle sensitivity. So the cycle refers to pressure-supported breath, and it refers to when actually cycle itself is a term that is used to mean when we switch from inspiration to exhalation. But we can change the sensitivity of the cycle setting during pressure-supported breaths. You can change the cycle in a mandatory breath typically by changing the inspiratory time. That will tell you how long your breath will last. But in a pressure support breath, remember, the patient triggers the breath with an inspiratory effort, and the breath is turned off based on when flow decreases to a set percentage of the peak flow. So here, if we have the peak flow here, as the lung fills and flow decelerates, when you hit 40% of the peak flow, that's a cycle sensitivity of 40%. You can reduce that cycle sensitivity actually down to 10%, and perhaps you could give that patient in the question that I asked you a little bit more support because you would extend the duration of the inspiratory effort, but you wouldn't fill the lung necessarily up quite as much. But remember, the important thing here is that when you talk about cycle sensitivity, you're talking about a percentage of peak flow. The higher the number, the closer you get to peak flow, and actually the less support you're giving to the patient. All right, let's switch gears for a moment and talk about the fact that we not only have different ventilators, but we also have different circuits to use. And there are 3 types of circuits that are typically used now. One, and probably most commonly in the machines that we use, is the passive circuit. It's a single tube. It's got basically a hole in it, and that is, if the hole may be in a mask if you're using non-invasive ventilation with a vented mask, or you might be using a device called a whisper swivel or another proprietary name. But basically, this is a fixed hole in the circuit, and it's called a passive leak circuit because all you're doing is letting air go out the hole. There are 2 types of active circuits. One is the active positive pressure circuit, and this really was the first type of circuit used for positive pressure ventilation. It's also a single tube, but it's got 2 little pressure lines. One is a proximal pressure monitor, and the other one pressurizes a mushroom valve so that the valve closes on inspiration and opens on exhalation. And then the other type of active circuit is an active flow circuit. It also uses a mushroom valve. This has a separate inspiratory limb here, and then air goes out the expiratory limb to this active valve that again will close on inspiration, open on exhalation, but you're also monitoring flow, and that is helping to trigger or end your breath. Now, certain machines will dictate which circuit we use. So The LTV and the Hamilton only use that active flow circuit. The Trilogy, the Astral, the Evo can use a passive leak circuit, an active PAP circuit, or an active flow circuit. So you've got lots more choices when you use those types of ventilators. Most people use a passive leak circuit, and so I want to talk a bit about that, and I'll compare it to the other two circuits. So remember, all you have is a hole, and if you don't provide continuous flow past that hole, then depending on how far away that hole is from the patient's airway opening, you're adding dead space to the circuit. And so we have to use an expiratory pressure in order to get continuous flow past that dead space to wash out CO2. When you use either the active PAP or the active flow circuit, you don't necessarily need to use an expiratory pressure, and that may be something that's more comfortable for your patient and a reason that you choose one of those circuits. The passive circuit really is king when it comes to leak compensation. Neither of these circuits does that very well. I wrote here available for the active flow, but that's really for the inspiratory triggering, not so much for delivering a breath. Depending on the machine, you can use different triggers to start the breath. So most of these machines use a flow trigger, but the Trilogy has certain proprietary algorithms that are called AutoTrack or AutoTrack sensitive that are only usable with a passive circuit. As I mentioned, you can use flow with the active PAP circuit, and with the Astral you could use either flow or pressure, should you choose to. Airway pressure is estimated with the passive circuit, as is tidal volume. Whereas, as I mentioned, there's a proximal pressure monitoring tube in the active PAP circuit, and you measure the inspiratory tidal volume. You're monitoring flow with the active flow circuit, and so you measure the exhale tidal volume with that circuit. Now, when we use a passive circuit, it's nice because it's easy, it's simple, it's lightweight, but as I mentioned, you have to use an expiratory pressure in order to get continuous flow. It's very good for leak, and so you can often see better synchrony with that type of a circuit, but because your flow goes up and down, your FiO2 may be variable because we're using low flow oxygen bled into the system. So if your flow goes from, say, 30 to 60 liters to compensate for a leak, your FiO2 may go from 0.3 down to 0.25, and you might not realize that. So if your patient requires a set FiO2, the leak circuit may not be good, especially if that patient has a leak. As I mentioned, it's great for leak compensation. Depending on your machine, you might have some limitations with how you trigger the passive circuit. I mentioned those algorithms, but depending on the machine, you may not be able to deliver a volume-controlled breath. So the Trilogy will allow you to use a passive circuit in volume control. The Astral will not. If you wanted to use a special mode, like average volume assured pressure support or intelligent volume assured pressure support, you have to use a passive circuit. One of the things you have to be careful of when you use a passive circuit, remember, that's just a hole, and if that hole gets blocked up, then what you've done is created dead space. And so a patient can become hypercapnic even though you've not changed any of your ventilator settings, just because that expiratory valve is obstructed. So make sure it's always visible when you're using a passive circuit. You may choose not to use the passive circuit. This is a reason that we chose against it. So this was a baby who had a giant omphalocele with pulmonary hypoplasia, and he also had a diaphragmatic hernia, and you can see his stomach sits well high up here. We transitioned him from his ICU to a portable ventilator, and his mother asked us please to use a Trilogy ventilator. So we used the Trilogy, and we used a passive circuit. As soon as we started to do that, he became intolerant of his feedings, and he developed pretty severe aerophagia, so that the nurses were constantly pulling air out of his stomach. And we reasoned that even though he had a cuff tracheostomy tube, all the excess flow was still overcoming that, and he developed pretty severe aerophagia. So we switched him to an active circuit that solved the problem. But this is the active flow circuit with a trilogy. It's got a little pneumotac, and you can see it's this big honking device, which is pretty inconvenient. So ultimately, we switched him to a different machine, as I'll show you in a moment, and it became much more convenient for him. So compare that active flow circuit to the LTV. There's the flow and pressure sensors for the LTV. Much more simple, and that's actually what he used until he became liberated from mechanical ventilation. So when we use an active flow circuit, you have to know where your flow sensor is, but I will tell you all of these machines are quite sensitive, even when the flow sensor is not right up against the airway opening. So as I mentioned, there's the flow sensor for the LTV, there's the flow sensor for the trilogy. The flow sensor for the Astral is back at the machine, but it's quite sensitive as well. So I want to show you why you might not want to use an active flow circuit when you've got a big leak. So this was a baby who came to me with an active flow circuit, and I'll be quiet so you can listen to him. His mom took these videos at home, so you'll notice he's got a big leak. He's using an active flow circuit, and watch what happens. She's going to turn back to him. And notice there's absolutely no synchrony, and the machine is not picking up his inspiratory effort. And actually the machine is triggering an alarm for apnea. So if we had not seen that video, we'd have gotten a different report. But seeing how big the leak was, we brought him to the office and switched his support to a passive circuit because that's great for leak. These are the settings that we used, and this is the outcome. Still has a big leak, but he's got great synchrony with the machine. And he's pretty comfortable. All right, well, here's another reason that we might choose a different circuit or a different machine. So this is a baby with severe BPD, as you can see. He failed transition to a trilogy. The minimum sensitivity, trigger sensitivity for the trilogy is 1 liter per minute. And so we switched him to an Astral with an active flow circuit where the minimum trigger sensitivity is 0.5 liter per minute. And as a result, well, if you listen, every breath is synchronized with the machine. And so these are the things that you have to consider when you're choosing your circuit and your machine, what your patient needs and what you can supply. So why choose one circuit over another? Well, I mentioned the simplicity of a passive leak circuit. The active circuit will be either a single or a double limb. Remember continuous flow, and that you have to use an expiratory pressure with a passive leak circuit, whether that's good or bad. Might make you decide one versus the other, because here PEEP or EPAP is optional. You've got choices with algorithms for your flow trigger with a passive circuit, whereas you only have flow or pressure depending on your machine with the active circuits. Depending on your machine, so if you have a trilogy, you could use a volume control mode, otherwise you're relegated to a pressure mode with a passive circuit, whereas you can use either pressure or volume with your active circuits. And you have more consistency with FiO2 with your active circuit than with that passive leak circuit. And again, you can use those nifty special modalities. So let's switch now to monitoring. Here's my second question for you guys. A 14-month-old with BPD is receiving mechanical ventilation via tracheostomy from a portable ventilator in pressure control, SIMV, and pressure support mode. He develops a mucus plug that obstructs 90% of the tracheostomy lumen. So which of these following alarms will be triggered? The low minute volume alarm, the high pressure alarm, the low pressure alarm, or the low PEEP alarm? Ooh, it's a horse race. All right, I think we have, all right, well, most people chose the high pressure alarm, but in fact that will not alarm when you are using a pressure control mode. All that will happen is you will hit your pressure. It won't deliver any breath to the baby, but you will not get a high pressure alarm when you're in pressure control mode with an obstruction. Instead, the alarm that will most likely go off would be your low minute volume alarm because you're not delivering the breath to the baby. So this is a critical thing to think about, and understanding your alarms and knowing that your alarms are set appropriately for your patient can be a life or death situation. Once again, Sheila and her colleagues did a simulation. She looked at small tracheostomy tubes and used different schemes of delivering breaths. And the take-home message of this slide is that when you've got and then she simulated a decannulation. So if the tracheostomy tube didn't become separated from the ventilator circuit but came out of the neck of the baby. And so you can see here all these no's mean that the alarm, the pressure alarm, never went off. And that's because there's enough resistance across that small tracheostomy tube that it generated pressure in the circuit high enough that it didn't trigger the pressure alarm. So you have to know how to set your alarms. You have to use backup alarms like the low minute volume alarm or apnea alarm. And most importantly, you can't rely on the ventilator alone to determine safety for your patient. The best monitor is an awake, alert human being, but we do use some other things to help the person out. So some people might think about using a cardiorespiratory monitor. Here's the one time you can say this baby's on an apnea monitor. But in fact, we don't typically use cardiorespiratory monitors. We find them duplicative. And think about it, you'd have to wait for an obstruction to cause bradycardia before that alarm would go off. And that's too long. So instead, we use oximetry. And in our program, we also use capnography for our patients with invasive mechanical ventilation. So when I think about monitoring, at a minimum, you want to use monitoring, aside from a human being, for any patient who cannot correct the problem or call for help. So anytime your patient's unobserved, and certainly when your patient's asleep. So some parents ask, do I have to have the pulse ox on all the time? Well, if that child's in direct observation and there is a capable person there, you might say it's okay to turn the alarm off under that situation. Think about it when you're using small tracheostomies, again, because of that risk of inadvertent decannulation that might not be detected by your ventilator. And then we use monitoring during weaning trials, which we do a lot of at home. All right, so when we think about monitoring, I've mentioned oximetry and capnography. And the other thing that we have to keep in mind is using clinical assessments, so looking at chest rise, ease of breathing, retractions, etc. We do other kind of monitoring at home, so if we think a patient's getting ill, we might ask for a sputum culture and gram stain. If we're using diuretics or other drugs, we can get chemistries and drug levels, etc. Those are all things that can help augment the physical findings that a parent or a nurse would tell us about. This is my little mnemonic for when somebody's acutely ill, all the things that you would ask about when you're taking a telephone call from a parent or a nurse to figure out what's going on. And remember, if you've got a child who's being ventilated invasively via tracheostomy, when in doubt, change it out. Oftentimes we fix things by just having the family do a trach change, and that mucus plug that they didn't think was there is gone, and that fixes the problem. But we can also make all different kinds of ventilator changes, and we do all of these things without necessarily bringing the child to the emergency department or to the hospital. So we can change pressures and volumes and pressure support and backup rates and even PEEP, as long as we have good communication with the family and a good observer at the other end of the line. We use a host of medications as well that you guys are all pretty familiar with. So you can imagine with a large group of patients, we have a pretty large team as well, and a team is critical in caring for these children. So it's not just docs, but we've got nurses and nurse practitioners, we have a respiratory therapist, we have social work, we have a nutritionist who's integral in helping us with growth and development for these kids, and then we use all kinds of other support services like PT, OT, and speech. The team coordinates care with the primary care docs, with home nursing agencies, with durable medical equipment companies. We review the treatment plans for the patients and sign off on them. We advocate with insurance companies and with schools and with whatever else we have to for the patient and the family. We'll provide medical direction, and we make sure the family knows if the child needs to come back to the hospital, we'll make it as easy as it can be to get them back here. We never want to set up barriers for that. We perform weaning trials at home, and we've liberated children at home without having to have them come into the hospital. As I've mentioned before, we can adjust meds and nutrition support. We can provide oral and parenteral medications, and we can alter mechanical ventilation as needed. We do lots of telephone management, and we do office management, and on unusual circumstances, we'll have an elective admission, and that may be because the child needs a procedure that must be done inpatient. Otherwise, most of this stuff is done on an outpatient basis. So then the question arises, when do you admit the patient? Well, if you've gotten to the point where you feel whatever you're doing for that child seems excessive, it might be more prudent to just bring the child into the hospital. If you can't figure out what's wrong with the child, it's better to just say, come in and let's let the dust settle and figure out, and we'll get other specialists involved. If you expect the child to do better and the child doesn't, that would be a reason to come in. And if anybody, parent, nurse, or you say, I just don't feel comfortable, that's enough. Just say, come in, let's be safe, and it'll cost you maybe overnight or a couple of days. We'll figure this out and get you home, and we'll avoid a tragedy. And so I'll end by saying there are some challenges to high-tech home care, but it's an awful lot of fun. So first and foremost, we want to improve the quality of life for our patients. We want to do it in a cost-effective way. We want to maintain services for kids and maybe even make them better. And one of the challenges we have now is to get respite care for caregivers who may be sleep deprived. Certainly think about being in an ICU 7 days a week without any respite. So it's something that we're fighting for, not easy to get. We're striving to integrate new technologies like telemedicine and some of the new changes in the home ventilators that we've got now. And ultimately, we want to find the best alternatives for the child and the child's family so that we can get some great outcomes. So thank you guys so much for your attention. Happy to take a question or two, whatever. And again, thank you.
Thanks, Howie. That was a really great talk. A lot of information. Looks like we have a question in the chat that asked, can you clarify why passive circuit is better for leak compensation?
So the passive circuit just refers to one that does not have any type of active valve. So if you're using a mask that's got to have holes in it of some kind, that's a passive circuit. Or if you're using the whisper swivel. So all of those are considered a passive circuit. And depending on the machine that you've got, They're pretty good at compensating for leak. Some will allow for leak up to 50 liters a minute. Typically, so one thing that's important to remember, if you're providing 4 centimeters of CPAP, then the leak through that circuit is 17 liters a minute. That's sort of standard for a standard circuit. When we're ventilating somebody, typically the leak should be around 30 liters per minute. If you're more than 40 liters per minute, there's probably too much of a leak if you're doing non-invasive ventilation, and you should be seeing if you can overcome that just to make your ventilation more efficient.
All right, thanks. Another question, do you have a guideline for trach placement in children with neurologic impairment? Looks like they're getting consults from the NICU for grade 4 IVH or severe traumatic brain injury in the PICU. How would you approach these consults?
Right, so first of all, it's always good to be asked before someone's made the decision so that you can weigh in. I think that on one hand of the balance, you have to understand the family's desires. And if, even a neurologically devastated child may be a source of love and comfort for a family, and in my view, it's not up to me to say that's wrong, and I would support that family as best as possible. What my job then is to explain what is required when we say we'd like to place a tracheostomy. And if the family understands what's required and still wants to go forward, then we tend to support the family in that decision, even though that might not be something that's right for us. I try not to project my own biases on the family in that situation. But what I do want to make sure of is that they understand all that that decision is, and that they don't make the decision lightly, that they're as well informed as they possibly could be.
Yeah. All right, thanks. Okay, next question. The question is, how can we do PEEP titrations clinically if we don't have an esophageal manometer?
Great question. When we're thinking about a child, so I'm going to answer that question in the context of intrinsic PEEP. And you can identify that when you, especially when you've got your trigger sensitivity set pretty low, and you go by and you watch a baby or a child making an inspiratory effort that never triggers the ventilator. And then you have to say, well, especially in the setting of an obstructive lung disease, you have to think maybe there's dynamic hyperinflation here and intrinsic PEEP, and you can look at your flow time tracing and see if that expiratory flow never goes to zero before the next breath. So, in addition to making some other changes in ventilation that would give the patient adequate expiratory time, one of the things you can do is put your hand on the diaphragm and watch your ventilator and slowly dial the PEEP up. And every time you feel the diaphragm contract or you feel that subcostal retraction, if there's no reward of a positive pressure breath, then you still have intrinsic PEEP, and you keep going until the child starts to inspire and trigger the ventilator with that effort. So that's one way that you can titrate for intrinsic PEEP. We do lots of PEEP titrations without esophageal manometry by using ventilator graphics. To do that, you really have to use a volume control mode, and the patient has to be relaxed. And you can decide based on mechanics like respiratory system compliance where you want to set your PEEP. You pretty much have to use an ICU ventilator to do that, although I guess you could do it with some of the graphics packages on a couple of these machines, but it would be easier to do with your ICU ventilator.
Great.
Sorry for
Okay.
that long-winded answer.
No, I mean, there's a lot of interest. So we have two more questions, and I think we'll be done. So the first is, At CHOP, are you sending kids home on the astral dual limb? Are there issues with the frequency of filter change, the requirements for frequent filter changes?
That must be a Seattle person, is my guess. So we had this discussion with folks in Seattle. We do almost universally use the dual limb circuit with the astral. The reason is we take advantage of that more sensitive trigger in that setting. And if there's, so one thing is we do not use wet nebulizer in line with the astral because it soils the expiratory valve. But if you're having problems, one of the fixes that we've used is to put a filter not only on the inspiratory limb, but on the expiratory limb proximal to the expiratory valve, and that protects it pretty well. So we have not had problems with frequent need to change out the expiratory valve in the system doing that, and using only metered dose inhalers, not nebulizers.
Great. We haven't had that one here yet, so I guess we'll find that out. Okay, and the last question was for patients you're concerned won't be able to trigger supported breaths. The question is there a specific ventilator or circuit you go to when you don't think the patient's going to be able to trigger the supported breath?
That's a really good question, and it's a very difficult situation. Going back to the astral for a moment, one of the modes that we've used in our kids with severe BPD has been pressure support with safety volume. And the EVO will do something similar. The point of all the ResMed machines is that they have, so we talked about cycle sensitivity, but there's also sort of a backup time setting that you can do for your inspiratory time. So you can set a minimum and maximum inspiratory time with those machines. The EVO can do the same thing. The Trilogy cannot. The LTV has in the internal settings a time termination setting, so it will do a maximum inspiratory time but not a minimum inspiratory time. So I'm changing the question for a moment and just mentioning that if you have somebody with a very stiff chest, using non-invasive in an ST mode might not be good because they may fill so fast that their cycle sensitivity shortens that breath. And so you want to make sure you have an adequate inspiratory time. So if you can set a minimum inspiratory time or overcome that using pressure control mode with the Trilogy, so where you set your inspiratory time, those are two fixes. For the child who is just not able to trigger a breath, we have resorted to using an assist control mode. It's not ideal, but if the child sort of gets a little agitated, at least when the ventilator gives a breath, it will give sort of the full breath and not just a tiny little pressure supported breath. It's still not ideal, so you have to do a lot of fudging in order to support that type of baby or child. I hope that helped.
Looks like it did. Thank you. Thanks for the great talk. Thanks for spending some extra time answering questions. Thanks to everybody who logged in today and had such great questions. Please don't forget to provide some feedback for us and register for the next talk on Monday. Thank you. Have a good night.
DB, thank you.
No problem. Thanks a lot.
Great.